So my name is Nach. For those who don't know, I'm a PGY4 anesthesia resident here at Western, and I was assigned to present on anesthesia for endoscopic neurosurgical procedures. The objectives of the talk today are to develop a classification system for endoscopic neurosurgical procedures. And then certainly this is not a comprehensive review, but I wanted to talk about some of the main important and commonly used places for endoscopic techniques. So this includes transsphenoidal procedures, and then their coexisting endocrine conditions and how to manage those. The evidence for whether a certain type of anesthetic technique is better or not. Talk about some of the literature surrounding endoscopic versus microscopic techniques for these procedures, the expected complications, and then I'll briefly touch on the endoscopic ventricular surgical procedures, as well as in the pediatric populations, craniosynostosis repair with endoscopic techniques, and then discuss some of the procedure-specific considerations. I wanted to really avoid going into the basic bread and butter stuff with regards to anesthesia considerations like having large bore IV access, art lines, so on and so forth. I really wanted to talk about the newest literature, because otherwise I would be kind of preaching to the choir as to what to do for neurosurgical techniques. So just wanted to focus more on that. That's just a caveat before I start. So in terms of kind of classifications, these two authors, Hoff and Przenski, back in 1998, defined endoscopic techniques into three major categories. So the first is purely endoscopic neurosurgery. So this is what you see here on the right, where you have a single burr hole going into the ventricle, and everything, including irrigation, any instruments, all are inserted through that single channel. So this is considered purely endoscopic neurosurgery. The second is classified as endoscope controlled microsurgery, which means that the endoscope is used for visualization. It's used as a light source, and then you have standard microsurgical instruments that are used, but the traditional microscope that's used in neurosurgery is not used. So oftentimes for skull-based surgery, this is kind of the hybrid combination that we might see. And then lastly, you have what we call endoscope-assisted neurosurgery, which is basically using a standard microscope and its associated instruments. However, an endoscope is used as an adjunctive tool for visualization and not necessarily for manipulation of any tissues. It just provides a kind of an alternate image and light source. So wanted to start off by talking about transsphenoidal skull-based surgeries, which is kind of the recurrent theme that keeps coming up with endoscopic techniques in my literature review. And one of the important things with these procedures is the coexisting endocrine conditions that can happen and the implications for anesthesia for those. And so, as we know, pituitary adenomas are a common reason for patients undergoing skull-based surgery endoscopically. And these are usually benign, and depending on the kind of the hormone production versus suppression, you can have unique anesthesia considerations in terms of altered physiology and some of the anatomic changes that occur as a result. So first thing I wanted to briefly discuss was acromegaly, which is, of course, a excess of growth hormone produced within the anterior pituitary, and it can have multi-system involvement. And I don't want to talk too much about that. This is just a screenshot from Coexisting Conditions by Stolting that lists the kind of system-based changes that occur with acromegaly. But I really wanted to focus on specific practical things that we need to know when we're taking care of these patients. And the main issue that can arise is airway issues in terms of difficulty with intubation, as well as potentially bag mask ventilation. And so there was a large systematic review done just last year in 2020. And this was actually an ENT paper that looked at the anatomic changes that occurred with acromegaly, specifically within the airway. And as you see here on your right, the picture is a fibroscope fiber optic laryngoscopy image showing the extensive amount of tissue overgrowth that has occurred within the glottic opening. And this can certainly pose difficulties for us when we're managing these patients' airways. And so on the left is a list of common, or rather the most common things that the authors found with regards to changes that occur. So you have arthritis of the cricoretinoid joint, you have irregularities in the vocal folds leading to impaired mobility of the cricoretinoid joints. Because of stretching within the larynx, you can have stretching of the recurrent laryngeal nerve leading to injury, and so on and so forth. So this can certainly be a challenge. And then in terms of some of the other important systemic complications that we may need to manage, cardiovascular disease is one of the most common features of acromegaly as well. And because growth hormone essentially stimulates the growth of any muscle, the cardiomyocytes are no different. And so you can imagine with excessive overgrowth of the cardiomyocytes, you may have ventricular hypertrophy leading to diastolic dysfunction, which may lead to systolic heart failure and eventually congestive heart failure altogether. And again, you can imagine because of the airway changes that occur, excessive overgrowth within the soft tissues of the airway can lead to obstructive sleep apnea, and that can eventually lead to heart failure as well. And then diabetes is also a very common finding within these patient populations. The second kind of very common finding is Cushing's disease in these patients, and ACTH secreting tumors are actually the most common pituitary hyper producing adenomas. And the important considerations for us would be the anatomical changes that occur. So the central obesity with the moon facies and buffalo hump on the neck can pose challenges with positioning and airway management. And similar to acromegaly, you can have obstructive sleep apnea, insulin resistance, a very, very high rate of hypercoagulability, and cardiovascular diseases as well. So just wanted to kind of highlight some of the important considerations that we need to have for this unique patient population if they're going to be undergoing transsphenoidal endoscopic surgery. And because the tumors occur in areas that are so close to producing so many different types of hormones, you can really have abnormalities in any of those. And I won't go into too much detail, but basically disorders of water metabolism are common prolactinomas, either excessive or not enough thyroid hormone production, and other clinically non-functioning tumors, but that may have anatomical considerations such as visual field defects and so on. So all of these are important considerations in this patient population. So what about outcomes? Whether endoscopic transsphenoidal surgery is any different than the traditional microscopic surgery. And so there was a large systematic review done just back in 2018 that looked at transsphenoidal endoscopic surgery specifically for Cushing's disease. And the figure on the right shows kind of their findings in terms of outcomes. And one of the things that they looked at was remission rate and recurrence rate between micro versus macroadenomas. So by definition, a microadenoma is less than 1 centimeter, and a macroadenoma is larger than 1 centimeter. And so you see that for smaller size tumors, the difference in remission and recurrence is pretty much the same between the two techniques. But for macroadenomas, the recurrence rate is much lower and the remission rate is much higher with endoscopic techniques. And the authors didn't really have a great explanation for this, but they were wondering whether maybe with the specific approach that they use endoscopically, they're able to better get at some of these tumor locations. But the difference between micro and macroadenomas is not really clear why. And they also looked at complication rates between endoscopic versus microscopic procedures in transsphenoidal surgery. And there's a few different complications here, but the one thing that does stick out, and something that's kind of recurred in me searching for some of the complications with endoscopic procedures, was this CSF leak. And the rate of CSF leak seems to be much, much higher with endoscopic techniques for transphenodal surgery rather than the microscopic techniques. So, so that's, again, an important consideration for us. Because one of the things that's been proposed to help reduce the risk of CSF leak is the use of lumbar spinal drains. And as mentioned, CSF leaks remain a major complication in endoscopic procedures. And so a recent RCT in 2018 looked at patients that underwent transphenodal surgery and those that had large intraoperative dural defects. And so when the patients had these surgeries and intraoperatively the surgeons noticed that they had to really manipulate the dura and had large dural defects that would require repair, they went ahead and repaired them surgically with the traditional techniques such as bone grafts that they would use. And then the patients were randomized to receiving a lumbar drain versus not receiving a lumbar drain. And the primary outcome they looked at was CSF leak at the 30-day mark. And what they found was the rate of CSF leaks are much, much lower in those patients that preemptively have a lumbar drain placed in endoscopic transphenodal procedures. So again, a consideration, since in certain centers, anesthesiologists are the ones that actually end up placing the lumbar drains, though that might not be the practice here. The next interesting thing with transphenodal surgery is the idea of mitigating blood loss. And so not a lot of literature necessarily exists for bleeding in transphenodal endoscopic surgeries in particular. However, there's lots and lots of data on endoscopic sinus surgeries. And so there's interesting talk about how some of these principles do overlap, because the approach that the ENT surgeons use initially to gain access for the neurosurgeons through the sinonasal cavities essentially use the same technique as functional endoscopic sinus surgeries. And so there's large amounts of data, and there's a systematic review done just earlier this year with over 1,000 patients that compared TIVA to volatiles. And this showed that TIVA had a significantly lower intraoperative bleeding score, lower rate of blood loss, lower estimated blood loss, with no real difference in cardiovascular signs. And TIVA really did show a significant benefit. And so although there are no RCTs, there was a retrospective study done back in 2018. It really was not so convincing for TIVA, but we may be able to extrapolate some of this data until we have good RCTs that perhaps TIVA would be beneficial for patients undergoing the transnasal approach. What about TXA? So again, recently in 2019, a meta-analysis done for various nasal procedures, but which included endoscopic sinus surgery, showed that TXA did have significant reductions in blood loss, surgical field quality, and eyelid erythema and edema and ecchymosis, which is associated with bleeding. And so again, this may be a consideration that we can apply to our specific patient population. So next, I wanted to talk about endoscopic ventricular surgery, which is sort of again, a broad area and a commonly used, a common area where endoscopic procedures are used. And endoscopic third ventriculostomy is oftentimes used for hydrocephalus in the pediatric population, for congenital aqueductal stenosis, for cauterizing areas of the choroid plexus that result in excessive CSF production, and for biopsying masses within the ventricular system. And so this is similar to kind of the first image that I showed you initially in terms of when we classify different types of endoscopic neurosurgical procedures. Here, for obstructive hydrocephalus, surgeons are able to insert a neuroendoscope directly with a single burr hole and then gain access into the third ventricle. And then because you have complete visualization, you can reach the foramen of Monroe and open the area of stenosis to allow for for CSF drainage. The anesthetic considerations for these procedures are fairly kind of standard neuroanesthesia considerations. Oftentimes in the pediatric population, you have other coexisting or syndromic features that warrant further investigation. Specifically with the irrigation fluids within the third ventricle, there's been reports of bradycardia and hypothermia that occur quite quickly. With febrile reactions as a result of the sudden change in the difference in fluid versus CSF chemistry, and then raised ICP with high irrigating pressure or volume. With regards to mechanical injury, depending on where the injury occurs, there's different kind of end sequelae. And so whether it's fornix or anterior, posterior, lateral, you can have different complications. And seizures are also one of the recurrent complications that kept coming up with, especially the pediatric populations undergoing third ventriculostomies. So what about the literature for ETV versus the traditional VP shunts that we oftentimes see? There was older systematic reviews done, one back in 2013, that showed fairly similar outcomes with maybe a slightly lower rate of complications in the ETV group, but not really statistically significant. However, a recent meta-analysis of RCTs done for obstructive hydrocephalus in particular, comparing ETV to VP shunts, showed that the rate of various complications, including infection rates, hematoma rates, and blockage rates, was much lower in the ETV group as compared to the VP shunt group. And there was really no difference in CSF leak, overall mortality, or the success rate. So certainly an important consideration when we're dealing with patients with obstructive hydrocephalus. And similarly, a meta-analysis done in only the pediatric patient population. The first one I talked about was in all patients. In pediatric patients in particular as well, there seems to be a definitive benefit to ETV. So maybe this is something that should be done a bit more routinely in the appropriate patients that we can discuss with neurosurgery. And then lastly, I wanted to talk about extraventricular endoscopic surgery. So craniosynostosis is one of the procedures done in pediatric populations that's, of course, associated with significant amounts of blood loss. And so endoscopic strip craniectomies are emerging as a preferred technique in many centers across the world, where basically the patient is placed in the prone position in between headrests, and then two skin incisions are made kind of perpendicular to the suture line. The endoscope is inserted, and basically a strip of the bone at the level of the suture that's preventing the cranial vault cavity from expanding is just removed in a little strip. And this is all done endoscopically. And so far, the outcomes have been relatively favorable compared to the open repair. The patient population usually better suited for this tends to be younger children, less than 3 months old, with single suture defects. However, this can be performed in older children and has been reported with multiple sutures as well. So the anesthetic considerations, again, this is not so much relevant to the patient population at UH, but certainly residents, we go down to Vic for pediatric craniosynostosis repairs all the time. So it's important to consider the other coexisting conditions that may exist in the pediatric patients who have craniosynostosis. And many of the conditions oftentimes have very difficult airways and are syndromic children. So that's an important consideration. And blood loss is, again, a major issue with open repair, but it can be significant with strip craniectomies as well, especially in the sagittal sutures where the emissary veins are in close proximity, and so this can result in significant blood loss. And then, of course, your standard considerations with venous air embolism and positioning. So lastly, I wanted to kind of talk about comparing extraventricular endoscopic surgery to the traditional open repair. And there was a multi-center propensity score matching study, so not RCTs, that compared ESC to open repair. And this was basically 31 pediatric centers kind of all across North America with over 1,300 patients. And you see the table on the right, which shows the p-values for various primary and secondary outcomes. And there are quite significant reductions in specifically bleeding, post-operative hospital stay, ICU stay, length of stay in hospital overall, operative and surgical times. All of those seem to be really favoring endoscopic repair. And though I haven't done many of these personally at Vic, the ones that I have seen have been open as well. So again, maybe an institutional thing, but certainly it seems to be the emerging trend for craniosynostosis repair in the appropriate patient populations. So the bottom line that I wanted to just wrap up is that for patients undergoing transsphenoidal surgery, especially for pituitary adenomas, it's really important to consider the other coexisting hormonal changes that may impact your anesthetic technique. And so coordination with endocrinology, making sure that their medications are appropriately managed is very important. Though there isn't necessarily a lot of literature surrounding outcomes with endoscopic transsphenoidal surgery, we can apply many of the same principles as endoscopic nasal surgery. And so there may be a benefit to TIVA and routinely giving TXA for endoscopic skull-based surgeries involving passages through the nasal sinuses. CSF leaks tend to be quite common with endoscopic transsphenoidal surgery, and so the discussion should be had with the neurosurgeons whether a lumbar drain might be helpful in this patient population. And extraventricular, endoscopic third ventriculostomy shows benefit over VP shunts for many complications such as infection rates and hematomas. So this is again something that may be useful in the appropriate patient populations. And same with craniosynostosis repairs. Strip craniectomies tend to be associated with significantly less blood loss, less hospital length of stay, and overall better outcomes as well. So again, something that may be an emerging trend that would be useful for us to know how to manage. And these are my references, and I look forward to answering any questions that people may have. Thanks.